right, we are going to get started. Good morning, everyone in Medical Alley. My name is Christy Pogachnik. I lead partner engagement for Medical Alley. Thank you for choosing to spend an hour of your morning with us to discuss the very relevant and popular topic, Care at Home from Idea to Implementation. If you're here today, I probably don't need to tell you that this is a topic that is really revolutionizing the healthcare industry. And we are fortunate to hear from a group of experts today to explore the multifaceted aspects of care at home. And they will be sharing their insights, experiences, and expertise with us today. So we thank them for that. Before I hand it over to them, I'd like to start by thanking Lee Branding for their support. These webinars are made possible because Lee Branding has invested in Medical Alley as a sponsor of our webinar series. So before we get started, let's learn a little bit more about Lee Branding. Awesome. Thank you once again, Lee Branding, for your generous sponsorship. I'll quickly note that there are other sponsorship opportunities available. So if your company is looking to find ways to build your brand in Medical Alley while supporting our mission to activate and amplify healthcare transformation, please reach out to any of us at Medical Alley or send an email to info@medicalalley.org. And with that, I would love to hand it over to our moderator, Erika Schuld. Erika serves as Operations Director of Senior Health and Palliative Care for Allina Health and brings many years of experience in the area of in-home primary care. Erika, take it away.
Thanks, Christy. Morning, everybody. It's great to be with you. When Christy and I originally met to chat through this, and she shared the revamped mission statement of Medical Alley to activate and amplify healthcare transformation, I thought, wow, this topic really fits in well with bringing healthcare home. And I know there's a lot of energy and focus on creating and improving how we collectively care for our patients at home. So I'm delighted that we're having time today dedicated to hear from a panel of experts who all bring a little bit different angle and flavor into how they do that. So we do have a couple of questions that I prepared and we'll walk through with the panelists. Just a quick couple of housekeeping items. Everyone is muted right now, which I think can be an excellent thing when there's large groups, because every once in a while you have that person that may forget to mute themselves again after asking a question. So if you do have questions along the way, there is a Q&A function at the bottom of your screen. So I'd invite you just to type in the questions that you do have, and I'll keep an eye on that as we're going through the presentation. And we'll also make sure that we leave some dedicated time at the end to field a couple of questions directly from you. So with that, I'm going to turn it over to our group of panelists to introduce themselves, and then we'll jump into our questions. So first, I would invite Rochelle to give a couple of words about yourself.
Good morning. Thank you, Erika. I'm Rochelle Wodarz, and I am the PCA Program Director at Accra Care. Accra provides many different types of home care, and I think a lot of people don't realize so many different types of home care exists, which will be exciting to talk a little bit about today. Accra's been around for about 30 years, and we provide services such as PCA services, which is personal care assistance. We provide financial management services. We provide 245D waivered services. So as an example of that, which when you say 245D, a lot of people don't know what that means. It includes respite, night supervision, homemaker services, caregiver living expenses, individualized community living supports. We also do skilled home health services. We have mental health services as well, and we have one assisted living. So thank you so much for having me here.
Thanks, Rochelle.
Yeah.
And Maureen?
Yeah, thank you. I'm Maureen Vantine. I am a nurse practitioner. I am Chief Nursing Officer and one of the co-founders at Mendota Health. And at Mendota Health, we provide advanced wound care in the home. Our company was started in 2020 during the COVID pandemic. And at that time, a lot of care was brought into the home. And the reimbursement landscape changed during that time, allowing more care to be brought into the home. And so now we're able to provide advanced wound procedures and treatments similar to what previously were only available in hospital-based wound centers. And we can provide those treatments right in the patient's private residence or assisted living facility. Typically, our patients require weekly visits. Previously, they would have to go to a wound center, and now we're able to come right into their home once a week. So it can be really challenging for homebound patients to get to any clinic once a week, and advanced wound care in the home allows us to bring that wound clinic right to them.
Erika, you're muted, but I can go next.
Oh, it had to happen at least once to me, right? You read my mind, Ashutosh. Thank you.
Absolutely. Hi, everybody. Good morning. Nice to be here. My name is Ashutosh Banerjee. I am the General Manager for Diagnostic Cardiology and Virtual Care at Home at GE Healthcare. So I represent the medtech side of things, and I'll try to bring in the hospital side of things. But as was mentioned by Erika in the opening, this is a topic that is very, very timely because COVID changed a few things around us. So we are all looking at virtual care at home and looking at it from several different lenses. So that will be really great for us to talk about. So excited to be here and for the discussion.
Alrighty, so we're going to jump into a couple of questions. And again, I'd invite everyone that if you're not hearing me ask a question that is really pressing on your mind, questions are that someone else on the line may have a similar question. So feel free to drop it in the Q&A section. And again, we'll leave some time dedicated at the end as well. With that, curious, and perhaps Ashutosh, you may want to field this one first. You know, it may seem obvious, but why care at home? And maybe some things you could touch on is how it may benefit either patient care, access, quality, cost, outcomes. There's a whole gamut of things that I think we could say to advocate for why care at home, but curious from your unique lens at GE, what you may want to offer to that.
Absolutely. Thank you for the question, Erika. It's definitely timely. So I would say that COVID, I was mentioning in my opening remarks that COVID changed quite a few things. What did it change? You may have heard about the fact that hospitals are stretched, healthcare workers are stretched. You hear about burnout, right? Why is that so? There is this, when COVID hit, the ICUs and the intensive care departments and the acute care departments, they were stretched. We had so many patients come into the ICUs that we had the regular ICU patients and maybe the planned surgeries and the scheduled operations and interventions all got postponed. Now that COVID is sort of settling in as an endemic, we are seeing the fallout of that coming in. So from 2 or 3 lenses. One, the healthcare providers themselves are really stretched out. Several of them have actually left their jobs in the hospital and they are considering different careers altogether. Patients are coming back in, cardiac patients, the other chronic disease patients, they're coming back in. Maybe they missed their checks and they missed going into the hospitals during COVID. The result is a concept called flex acuity. Hospitals are looking to expand the capacity of their hospital. They are looking to see how they can bring in the more acute patients in the hospital and maybe take care of the less acute patients in some other way. An example is this, like if you have arrhythmia, for example, which is a condition in which your heart has irregular beating and it could lead to AFib, you may not be a candidate for staying the night in the ED or staying the night in an ICU. But the fact is that the AFib patients are actually frequent flyers into the ED. They get a symptom in the night and they rush to the ED. And of course, when they come to the ED, you have to take care of them. what if you could send them home, or better still, take care of them at home, so that they do not need to come to the ED, and the ED doesn't get overcrowded and it's left free for patients who really need it. So that has been sort of the accelerator for hospital systems looking at home monitoring and home care as a way of relieving the stress on the hospital system itself, from a capacity point of view, also from a cost point of view. As you may well imagine, that taking care of a patient at home has two benefits. One, patients usually recover better at home. There are lots of studies that talk about that versus recovering in a hospital. And second, from a cost point of view, the home is a lower cost place than a hospital, right? So that has really driven care at home. So the why care at home is a question I think that the hospital systems have put to bed, literally, during the COVID. And they are now thinking of how do we accelerate that, and how do we really take care of people at home by providing maybe lower acuity care at home, or doing patient monitoring, patient management at home, so that the cost in the hospital as well as capacity, those two are taken care of.
Thanks, Ashutosh. So we just heard him talk about some of the reasons from perspective of a healthcare system of improving capacity on the hospital side, increased convenience for patients at home, and also that reduction of cost, and how monitoring and technology could support those aims. And would invite Maureen and or Rochelle, if you wanted to share from your perspectives, either from wound care, in-home, home care related initiatives, how you may answer that question.
Sure, I could jump in here. Thank you, Erika. And yes, I agree, Ashutosh. Care at home can open up capabilities for the healthcare team and hospitals. But really, one of the best things about care in the home is that it's convenient for patients and it leads to greater patient satisfaction. Anybody would rather be in their home than in a hospital. And also, speaking about not just hospital, but clinic visits. So again, our wound care patients require weekly visits. And to get to a wound clinic once a week is a huge undertaking for a patient, and also for their families and their care team. So by bringing wound care to the home, we're avoiding the need to arrange transportation. We're avoiding the need to have family members available, taking what could be a half or a full day of their time to get their loved one to an appointment. And all of these barriers that make it difficult for patients to get to appointments also contribute to a decreased access to care, because patients end up missing their appointments. And if and that leads to quality. So quality care is contingent on access to care. And if a patient is missing a lot of appointments, then we lose momentum in their treatment plan, and they just won't receive the care that they need, and they won't achieve the desired outcome of, in our case, wound healing. So achieving that outcome of wound healing is obviously the best thing for the patient, but also it's the best thing for the healthcare system. Health and healing always leads to cost containment. Sick people consume a lot of healthcare resources. And so if we can take care of them more efficiently in their home, it's going to lead to better quality and cost containment, but also a much better experience for the patient.
Thanks, Maureen. And I know you're answering it specific from your current point of view of wound clinic, but for everyone, probably this is obvious, but we'll just name it. That same sentiment of bringing a specific service that you can extrapolate to any specialty or primary care, how much more convenient it is for patients and their families not to have to worry about how to set up transportation. Maybe it's taking time off of work that someone may have to do to grab mom or dad to bring them in for a visit. So appreciate that point of view, Maureen. And Rochelle, is there anything that you may want to add to that?
Yeah, I have a couple things. I would echo what both Maureen and Ashutosh have talked about, especially regarding that, recovering at home. Our home is our safe place. Typically our home is our sanctuary. It's where we're most comfortable. It's where all our things are. It's where our people are. and to allow the opportunity for people to stay in their home and receive the care that they need increases, the recovery, the outcomes, satisfaction, quality, et cetera. The other thing I wanted to talk about is just highlighting all of the different kinds of home care or care that can be provided in the home. There is when I meet people and they don't know much about home care and they start asking me what I do or what types of home care we provide, a lot of people have in their head that we only take care of elderly individuals. And that is by far and away not the only, of course, and they're shocked to learn that there are situations where we will set up home care providers will set up mini ICUs in the home, and again we talk about the cost containment there. It costs significantly less. It costs about $5,000 a day to be in the ICU in the hospital. It costs far less than half of that to be at home and to get that same care where you're in your safe place, where that, you think about the mental health factors that we have when we're in the most stressful times of our lives, when something has occurred, an event, a surgery, and we're trying to recover. Being at home is the best place to do that. And talking again about the not having to go into inpatient, even for follow-up appointments or for cares that need to be provided or therapies. And when I think about the tundra that we had this last winter in Minnesota, getting out even in the summer right now, even when we have lovely weather, is difficult and stressful. But then when we've got 10 inches of snow and we've got ice and all of the things. So there's so many reasons that home care is so important, as well as there are other types of home care too, where people have a need that is chronic. It is maybe they have a diagnosis that's lifelong, maybe it's a disability, and they need just a little bit of care at home. It may not be skilled and it could be long-term, but it's an additional service to help them stay to really maximize the independence that they have and to stay in their homes as long as possible, which again is where people they want to be home with their people, with their family, with their loved ones, and or in their safe space. So many benefits to home care. And I think when we were talking about this earlier a couple of days ago, I said I could go on and on about the benefits of home care, but I will stop for the moment.
Good. We can tell the passion, which is great, and that's why you're here. So
Yes.
All right, before I hop into the next question, I just want to acknowledge that there's been some activity on the Q&A and also say thank you. Always appreciate when it's a more engaged back and forth. So thanks folks for popping in some questions here. So for Mary, the next question will weave in some pieces about reimbursement. So we'll get there momentarily. And then there were a couple of anonymous attendee comments, questions here. So that second one was around, in reality, not all patients' homes are where the patient prefers to be, and it's not always as convenient for patients and may not always be safe, et cetera. So I will affirm, I also believe this to be true. It is true, particularly coming from a large healthcare system. We'll name that we do always need acute bricks and mortar settings. And I don't think that's ever going to go away. And that is very much needed. And in a lot of occurrences, that is the best and the safest place for a patient to receive care. The angle of this conversation is, the premise there is, if a patient does not clinically need a level of care setting that is, say, hospital acute care, what can we do to rally resources and expertise to care for patients at home? And part of that kind of second piece, and as well as I think the third comment, is around safety and liability. And I do also, as teaser, have a question, I believe it's in 2 questions from now, that will touch on what we need to do and what the responsibility is to keep not only patients safe at home, but also our care team going out, because you're absolutely right. it can sometimes feel like the Wild West when we're asking someone to step into a patient's home. You don't know what you're going to get. You don't know if it's going to be a hoarding situation, if there's going to be, an aggressive dog. So absolutely, there's a lot of extra things that come into play when we're serving patients kind of on their home turf. So we will touch on that. Thank you for the activity and the questions. And then please, again, keep them coming. We appreciate it. So with that, I'm going to move us into our second question, which is how we can ensure that care at home is accessible to everyone who needs it. And I know there's a couple angles that we'll likely hit on with this, and I'll invite Maureen first to answer this question. If you could maybe weave in some reimbursement pieces as well.
Sure. So how can we ensure that care at home is accessible? I think one of the challenges that we find providing our specialty care in the home is that the patient has to receive their other care, their primary care and their other specialty care and diagnostic testing. And often all of those things are not available in the home. We appreciate organizations like what Rochelle has spoken to that provide primary care in the home. That is so great for us to have our patients have access to that. But often, we may order a test or a lab or something, and they do need to leave the home to get that. So that can be challenging for us, because sometimes our patients say, well, I don't want to leave the home. That's why you're here. And so I would challenge all of us in healthcare to think creatively about the various primary and specialty care services that people need that we're currently providing in clinic settings, and ask ourselves whether that care can translate well into the home. Is there a benefit to the patient or the healthcare system to bring that care into the home? And is reimbursement available for that care? And if it's not, can we work to create a landscape where that care is reimbursed in the home? That is one of the things that we're doing at Mendota Health. Some of the services that we provide are reimbursed in the home, and not all of them are. So we are leveraging some of our partnerships to petition CMS and work towards getting improved reimbursement. So that's something that we in the healthcare system can proactively work towards. And I'd love to see a landscape going forward where more of that care not only can be done in the home, but is reimbursed as well.
Maureen. Rochelle, Ashutosh, who wants to go next?
Go ahead, Rochelle.
Okay, thank you. With regards to accessibility to home care, it can be an overwhelming system to navigate. And it is important, I think, for us to be aware of the resources that are available to help people navigate through all of that, through the options, through the system, through all of the different avenues for, that where payers will provide and to reimburse for home care services. It's also something, important for us at Accra, and I think many other organizations provide navigation of that. So when somebody contacts a provider, whether it's a hospital or a home care provider or any type of provider, to have a navigation system or individuals or team available to help really kind of navigate through that. It can be overwhelming. There are so many different types of home care, like I said, and there's also, everybody has different things in place with regards to, my insurance. Does my insurance cover this? I'm on medical assistance. What does medical assistance cover? Is there a county-based waiver that may provide an opportunity for me to access a service that makes the most sense for me and the needs that I have? And like I said, if you're not in the system, it can be very overwhelming. And again, when people are really in need of that care, it can be stressful. There are so many things going on in people's lives. And so the more we can do to provide those services, those resources, to have experts on our teams and also for us to be collaborating across the continuum so that, if somebody is in need, that we're able to reach out to their payer or reach out to their county-based case manager or a care coordinator with a managed care organization or a social worker in the hospital or at the clinic where they're getting services, where we can all really work together to identify and get that person an assessment for what is going to be the best service possible for them, and then help them navigate through how that is going to be covered.
I think those are great points, Rochelle and Maureen, and both of you talked about the insurance aspect, the affordability, and the suitability maybe of the care. Let me also start by narrowing the scope a bit, if you are okay, Erika, because care at home is such a broad phrase that it can cover a wide variety of offerings, right? So in the past, pre-COVID, care at home used to almost exclusively mean somebody goes into the home and provides services, right? Before COVID also, it was evolving towards where remote patient monitoring could happen. And I see several questions in the chat, in the Q&A section about those, right? So the challenges that we are facing in the hospital are because we need people and human beings to deliver most of the care supported by technology, right? If we try to scale the same way at home, then we are not going to scale because the same challenges remain. On the other hand, we have remote patient monitoring. Let's look at the number of patients who need remote patient monitoring. Let me give you an example. 133 million people in the US alone, 45% of the US population has a chronic condition. 50% of those have multiple chronic conditions. That's a lot of people, right? All of them can benefit from remotely monitoring their vitals and their progress over a period of time. Like if you have hypertension, like I have hypertension, I don't really need to go to the hospital every day. If I am good and on top of my medication, and if I measure my blood pressure and my vitals regularly, then I'm good, right? But a lot of people are in that category, and 50% of the people who are polychronic, more than one chronic condition, they would need some kind of active remote patient monitoring. So let me narrow my answer down to the technology part of it, because the care provided by people going into the home is something that is scalable to a certain point. But if you need to scale and go beyond the 5% of the target population who have remote patient monitoring today, then you need to rely on technology. So there is a question from Stacy around whether it's easy to implement the systems and challenging historically to meet IT requirements. So the ability to scale will depend on two things. How friendly is that technology for people at home, especially those who are not very, let's say, comfortable with technology, right? Everybody is not comfortable with touchscreen phones and stuff like that, right? The second part of it would be how comfortable are healthcare systems from a IT cybersecurity requirement to deploy those technologies at home. And I would say that today's healthcare technologies have really evolved from where they were in the past. Today, most of them rely on one of the 3 or 4 big cloud providers, so either Amazon or Azure or Google, and they are very much ahead in terms of the cybersecurity practices and the way their systems are healthcare compliant, whether they're HIPAA compliant or their patient privacy or cybersecurity are really taken care of. The second is the technology itself. Any good RPM or remote patient monitoring offering needs to be scalable and adaptable. So you need to be able to give an IVR system where you can dial into a number or you can get a phone call if there is an issue. And it should also be for people who are really comfortable with technology to be able to use a tablet or a phone and manage everything without ever talking to a human being. You can just maybe text or type and go ahead. Maybe the newer generation, I would dare say, would really like that. They would rather text than call, right? As I'm sure all of us who are parents would know that. So how is the technology scalable and how comfortable is it for anyone to use it? Wearables have become smaller and they have become more comfortable to use. A lot of people have Apple Watches today, and Apple Watch is actually a pretty good normal for very less severe chronic cases, they're pretty good. You are able to see your heart rate, you're able to see whether you're walking enough or not, and whether you're active or not, right? So starting from there, going on to more advanced level of technologies, I would say the technology has evolved. I would say the cybersecurity requirements have evolved. I would say that the adaptability has also evolved. Where I think we need to do more is how do we provide this access irrespective of where you are. If you are in rural America or in a remote corner of Africa, do you have the same access to technologies and as you could have in an urban city anywhere in the world, right? So that is something which we still need to work on. We also need to work on how do we make the workflows seamless and easy. There are a lot of questions around social determinants of health, whether you are in a good place or not, whether you are able to access technology, make sense of it, and access care, right? So how do we integrate that into the workflow? There's still some work that's needed there, but I would say technology is actually not a bottleneck today. It can be made adaptable, scalable. It's the workflow and the integration with the care team's workflow in the hospital that is important.
Thanks so much, Ashutosh. Before we jump into the next question here, and I'm just trying to keep tabs on the incoming Q&A and appreciate the activity here. So one that I don't know if we're going to naturally get into in our next couple of questions, I'm just going to pick those out here. So I see one about, tell us about hiring providers and staff for home health care. Is the staffing market strong or evolving? I can touch on this, and then we'll invite my colleague panelists here if they have any specific insights. That would be fabulous. So I'll say from our point of view, on the provider side, yes, I think it's tight in healthcare, regardless of what the discipline is you're going after. We haven't seen quite as much difficulty on the provider hiring side, really where a lot of the energy has been focused in our hiring efforts has been around nursing. And I think we're not alone there. It's a finite pool of folks that a lot of people are vying for. And I feel like the reality is there's a special breed of folks who are comfortable and are driven to home-based care. It's really the reality is that if you're out on a visit, it's you in the patient's home. It's not you and you can, turn around and, if you're in a clinic or a hospital, you have a provider there, 3 nursing friends, an aide. It's you're kind of it in the moment. And so it does take someone who's comfortable and really drives their energy from kind of that level of independence. So sometimes it can be a little bit more difficult to find someone who doesn't just have the clinical competencies, but also just the kind of the drive or the passion for home-based care. So I will turn it over if anyone else wanted to touch on the hiring piece.
I can touch on that. Erika, I couldn't agree more. It's really about finding the right providers. From our perspective, we do send nurse practitioners into the home. So we are hiring providers specifically. And I think it really helps to do a ride along prior to bringing that person on board, because most people haven't done home-based care. And I think it's very helpful to go out into the home as a provider and see what this really means. I agree, Erika, that the provider is sort of the provider and the nurse and the front desk staff. Not to say that they're doing all of those roles, because we do have remote support in the way of scheduling patients and finding diagnostic tests and things like that. So we have remote support, but we don't have in-person support for our providers. So the provider has to be comfortable getting their hands dirty a little bit. And so that's part of it. But also on the other side, it's not that same hamster on a wheel feeling that you sometimes get in a traditional clinic setting, where it's just, churning patients in, churning patients out, going from room to room to room, and kind of never seeing the light of day. We do have the opportunity to spend more time with our patients. Our visits are 1 to 2 hours long. And so you really develop a amazing rapport with patients. And so if you find a provider that really values that relationship building over time, those are really the people that you're looking for. So I won't say that it's hard to find providers, but we are very intentional about making sure that we're finding the right people that are going to thrive in this environment.
Maybe if I can, Erika, add one more point to the hiring, if you're
Go
okay.
ahead.
I would just say that one of the drivers for remote monitoring is also the fact that it is difficult to find the right caregivers, to Maureen's point earlier, in the hospital and for providing the care live, right? So I would say that the balance has to be found. There has to be a balance between finding the right skill set for delivering care in person and the technology part of it. I would say it is still difficult to find the right people. Hiring is still a challenge, and that's part of the reason why healthcare providers are coming to all providers like where Maureen, Rochelle, and I work to work for providing care at home, because that is a scalable model. If you have the right balance between technology and people, it's something that can take care of the challenge today that we have in finding people. Is the right skill set, the right mentality of people who really have to provide this care. That's always a challenge, right?
Thank you so much. Alrighty, I have definitely seen a trend here in the chat Q&A around safety at home. So I'm going to pivot us to another question which will incorporate this, which is, what are some challenges, including some of the ethical considerations around providing care at home? And Rochelle, I'm going to invite you first, if you wouldn't mind, to answer, because I know you have some kind of expertise around the provider and patient safety aspect.
Yeah, it's an excellent point, an excellent question. When you're going into people's homes, you do not know what you're going to encounter. Everybody has a different environment, a different way that they live. We mentioned earlier, are there dogs? Is it a safe place? Is it safe for the client, patient? We call our recipients clients. So I'll go back and forth with that. But and is it safe for them, and is it safe for the caregiver that's going into the home to provide the care, or individuals that are going in to supervise the care? That safety has been a big topic of conversation for us at Accra, and we have put some things in place where you may have gone into somebody's home before. Many of our clients are with us for long periods of time. And so we do get the opportunity to establish some amazing relationships. And we may know that there may be a situation that it might be best to have a buddy with us. So we may have two people go into a home. But we also recently started using a safety device called, and we work with the Katana organization with that. And so every single one of our individuals that go into a client's home will have that device on them, so that if something were to happen, there is they have a lifeline right there. They have, or if they're just not quite sure and they want it's called a walk along, they will be able to execute that. And so that there's somebody right there knowing, like, they're there if something happens. And that we've got different things to institute if something were to occur, that we can get help to them real quick. So that's been big. It is safety is a big piece. And when we talk about, the last question with recruiting and with hiring, and it's true, the workforce is, we're all vying for the same, individuals, especially the nurses. But across the board, it's got to be the right person, and making sure that person understands you don't know what you're walking into. We will do everything we can to ensure that you're safe. And then, of course, when we go in, we want to make sure part of our assessing every situation is ensuring our clients, our patients are safe and they're receiving the right level of care. And again, going back to the collaboration across the continuum of care to make sure we're all working together as a team to make sure that that person is getting what they need. So that's kind of my topic on safety. And I know that Maureen and Ashutosh have some topics on that or some points on that as well.
Thanks, Rochelle. Maureen, would you want to jump in next?
Sure. Thank you, Rochelle, for sharing what you guys do to provide safety for your providers. We actually do something similar. We also have a remote monitoring app, very similar to what you described. So it's interesting to hear that, so many of us are finding similar solutions to common problems. So in speaking to some of the ethical considerations about providing care at home, one of the things I think about is scope of practice. So as an in-home provider, we're advanced wound care providers, but also we're going into the home, and sometimes we're the only in-home provider that our patients have. And so we do develop those close relationships with them, and they do trust us, and we see them a lot, once a week for an hour at a time, which is definitely more than they see any of their other providers in a lot of cases. So we just get that unique perspective, and often we will uncover other concerns while we're there, other healthcare problems that they may be having. And so I think it's important to remember scope of practice and to coordinate and collaborate with the rest of the healthcare team, whether they are in the home or not. So of course, we want to take care of the patient first and foremost, and it can be tempting as a provider that, providers have varying levels of experience. It can be tempting to just take care of the patient because we're there and we want to do the right thing, but it's also really important that we're not practicing medicine in a silo. And so, we really are intentional about collaboration and communication. If we uncover another problem that's unrelated to the wound, we will call the patient's primary care provider and make sure that we have a conversation with them and ensure that we're all on the same page with providing that patient's care. So additionally, I think speaking to scope of practice too, it's important to consider whether the care that you're providing is actually appropriate for the home setting. Some patients really are high risk, and some procedures in those high risk patients may be more appropriate for a clinic or a hospital setting where they have more resources available. And so it's important to make those assessments. But conversely, we believe that in many cases, the benefit of providing care in the home really outweighs the risks, and that's why we do what we do. So thank you for the opportunity to speak to that.
Yeah, thanks,
Great,
Maureen.
great
And
points.
something.
Sorry, go ahead, Erika.
Sorry, I was just going to jump in. I'll turn it back over to you, Ashutosh. What you were saying really is ringing true to me as well, Maureen, of when a clinician's in the home. And I think a lot of it too is just because people who are driven into healthcare just tend to have really big hearts and they want to help. So there's that temptation that as you start to get to know a patient, you see other things to just fix it all, do it all. And it's hard to always remember, but key to remember that scope of practice piece and staying in a lane and then leveraging other healthcare team members. So Ashutosh, what would you want to add to this question around some challenges or ethical considerations?
Yeah, absolutely. And didn't mean to interrupt. Sorry about that. So, some of the challenges are what both Maureen and Rochelle talked about. Are we providing the right care? About care appropriateness and the level of care, right? There are a lot of questions on the Q&A also that I see around safety, level of care. Are we really, is it a really safe place, and is the home set up for the kind of care that we need, right? So I would like to say that a scalable and a effective home care solution is the one that not only takes care of the technology, the people who are providing the care and looking at the vitals from the patients, but also take into account the environment in the home and the social, what are called the social determinants of health for the patients at home, right? So I'll give you an example. For hospital at home, And that term is also much misused as well, or maligned as well, because hospital at home, technically anything that you provide at home could be called that. But what I'm referring to is specifically when you provide an ED or an ICU level care at home, minus the ventilation. You're not intubating a patient at home, but you are providing an acute level of care at home. And so the requirements for that are not only the technology, it is also the clinicians who need to be available to go at least once a day per CMS rules, but also the appropriateness of the home. We are not going to do an acute care at home if there is no electricity, or there is no air conditioning, or there is no, you don't have a good telecom network there, or you're not going to have a good Wi-Fi there. So for us to provide those, we either need to provide those ancillary services, make the home safe, as well as ensure that we can continue the care there without interruption, or we move the patient to a better location that can actually take care of that. So the appropriateness of the care provided, the appropriateness of the level of care provided, we cannot intubate a patient at home. It is too risky. You're not going to do that even if we can, right? Even if technology supports it. So that is very important for us, and that's where some of the ethical considerations come in as well. Just because hospital systems and all of us here want to earn a decent profit on things that we do, does not mean that we provide care wherever we need to and wherever we can, but it has to be based on the patient need and whether we can do it sustainably and in a manner that will put the patient first and put the patient in the center. Back to Erika.
Thanks, Ashutosh. Alrighty, I'm just taking another peek here at our Q&A questions. Alrighty. We'll try to get to all of them, do our very best. If we're unable to, and if I'm missing something here, again, we'll leave about 5 minutes at the end, and we will jump into additional questions. Alrighty. Next, we're going to go to just the role of people in providing care at home. So it could be care providers, administration of the programs. So to our panelists, how does the role of people really come into play in providing care at home? Maureen?
Go first. Yeah, go ahead, Maureen.
Yeah, so I think the roles, I alluded to this a little bit in one of the other comments. The care providers are filling the care provider role in that they're directing care, but they're also, in our case, performing wound care, actually physically doing the wound care, providing the advanced treatment and changing the dressing, and wrapping the leg, or assisting the patient to put their shoes on or whatever it is to finish out that visit. And also there is an element of ensuring that doing a little bit of front desk staff work too. Often our providers will call ahead and let the patient know that they're on their way, and getting consent signed and things like that. So there is a lot of sort of crossover in terms of the roles there. And then in speaking about some of the other, office staff or medical assistant staff, many of them are working remotely. And so they have some of the challenges of remote work, meaning they're supporting the provider, but remotely and not sort of elbow to elbow in a clinic. So I think that's kind of the how the role of people changes in our organization. There is definitely a need for communication internally as well, and so you leverage a lot of those technologies that we're all kind of used to leveraging, but sometimes new challenges crop up with them, with regard to text and email and HIPAA compliant platforms and things like that.
Thanks, Maureen. And I had seen, Ashutosh, that you had taken yourself off of mute. So were you planning on jumping in on this one as well?
Yeah, I could provide, because from the from the hospital side of things, the role of people would change in the fact that we have to blend in technology in the way care is provided. So there are quite a few different roles that are coming up. There's the role of the health navigator, who really looks at manages maybe a case manager or a health navigator managing maybe 100 to 150 patients in a way that you are looking at the trends of the patient's vitals and their questionnaires over a period of time, and you are in touch with them but not every day, right? And you are sort of managing chronic patients over a period of time and directing some of them to the hospital when needed, not if needed. If you can keep them out of the hospital, that's great. So that kind of a role has been evolving. The role of care providers, like going into the homes, also is evolving. You can rely a little bit more on technologies. Of course, on wound care, you cannot really, Maureen will tell me that you cannot really take care of the patient without really going in and doing something about the wound. But cases like that, definitely. But in cases where you can do remote work and remote diagnosis, like for example, telehealth. So in the past, I would say very few hospitals would have had a virtual visit option. I can say today that there is virtually no hospital today in the US that doesn't have a virtual visit option, available for their patients, right? You can actually do a virtual call for general cases, and a doctor sitting in California can take a look at the patient in Wisconsin and so on. So the role is evolving. We are trying to see how we can help clinicians take care of more patients but still have the same outcome. And we are trying to see how we can blend in technologies seamlessly into the care role for most of the use cases, not of course everything, but for most of the use cases.
Thanks, Ashutosh. And I'm just going to weave in here because I saw there was a comment in the Q&A about how caregivers fit into all of this. And I'll just start by saying caregivers, I think increasingly so when we're able to do more and more in the home, are really becoming a vital part of a patient's care circle and care team. And the importance of making sure that if a patient isn't able to do everything in terms of medication administration, maybe it's home therapies, whatever it may be, if they're not independently able to follow their recommended care plan in home. Because again, the reality is that there's all of these amazing wraparound services that we can collectively in different parts of our healthcare ecosystem bring into the home. There's not typically, a nurse or a provider who's physically there 24/7. And so there does need to be that element of either the patient able to do some things that will enable them to stay safely in home, or they need to rely on a caregiver. So there's that huge important piece of making sure that the caregiver as well understands all of the instructions. If there's remote monitoring in play, that they also were taught how to turn on, how frequently should I be testing and checking these vitals, et cetera. So we'll just offer the affirmation that yes, caregivers are so critical to keeping the patient safe at home. That's just my 2 cents. And I will turn to the expert panelists here if there's anything you may want to add around incorporating a caregiver into course of treatment, keeping patients safe at home.
I can jump in on that. As you mentioned, the need for there to be flexibility is huge in home care because things do change, and because when a clinician goes into the home, or when a paid caregiver may go into the home, they may see things that come up, or things may be shared with them that identifies another need. Caregivers are going to, paid caregivers and unpaid caregivers are going to, they're going to see and they're going to hear a lot of things. And it's important for us to be going back to and talking with the providers and the appropriate people to make sure that we're always getting the appropriate level of care, which we've talked about just a little bit ago. And what you were referring to is in the importance of having a caregiver. Not everybody's able to direct their own cares that get services in the home. And it is important that there is another family member, or there is somebody else that we may call them a responsible party. We may call them the primary caregiver, for there to be somebody that is overseeing those services and those needs, so that they're communicating back to the providers, and we're able to ask really valid questions and get really solid answers as to what's going on and how we can best serve that recipient, that patient, the client. So yeah, caregiver, the role of people is significant. The importance of open communication, honest communication, and really making sure that nobody's going in any situation judging. It can be, something when I interview people that are going to be going to the homes for the very first time, to say, you're going to see a lot of things. You may go into a home and they may live very differently than you may choose to live. It is not your place to judge that. It is your place to be there to ensure that, you're assessing the health and safety needs across the board, of course, when you're providing those cares, and identifying the needs along the way, but really being careful not to judge and impose our thoughts or opinions on how they should be living they're in their home, living their lives, caring for themselves. Everybody's different. So
Thanks, Rochelle. I just got the side chat friendly reminder of the time at 10:57. What tends to happen is I get really energized. You can probably tell the panelists are very energized by this topic, and we start talking. We're almost at time. So I am going to end with one final question for our panelists, and then we'll turn it back over to Christy. So we've been talking a lot around the unique challenges specific to providing care at home, and perhaps just to end on a note of lightness or positivity, we'll end with this one. So how can we kind of collectively encourage public acceptance of care at home? So maybe it's a policy implication, lobbying efforts, however you may want to tackle this one. And again, we'll shoot for being done here in about 60 seconds so that we can turn it over to Christy and make sure that we get folks on time for their next engagements of the day. So Rochelle, Maureen, Ashutosh, anyone want to field that one?
So I can go first. So there are obviously, so 60 seconds, right? So let me give you 30 seconds or 20 seconds of mine. So I would say there are policy implications, but policy is evolving. There could be more done there. There is a lot of acceptance within the hospital space as well, for silos to be broken down within hospitals itself. And then awareness amongst the general population about the availability of such technology-based services that they can avail at home. I think the latter is where all of us can really hold hands and create awareness among the patient population that this is available.
Thanks, Ashutosh. Great job wedging it into 30 seconds I left you. Okay, with that, I'll just say thanks so much, everyone, for the time today and the opportunity to talk about a subject that is near and dear to a lot of us. And I will turn it over to Christy.
All right, thank you so much, Erika, Rochelle, Maureen, Ashutosh. This was such an informative session. We really appreciate you coming on today and exploring this topic with us. I think we got to all of the questions. Thank you so much, Erika, for helping to field those. If there are other questions you didn't get answered today, please connect with me. I can help you connect with either our panelists or someone else who can help you with your question. Thank you again, everyone, for tuning in today. And before we go, I just want to once again thank, of course, Lee Branding for sponsoring this webinar series, and to remind you that we do have some more events coming up. On July 12th, we have a webinar on growing your international sales with our program, Medical Alley Global. We have another webinar on July 18th, Innovation in Pre-Hospital Care. And on September 26th is our next in-person event, which is Equity in the Alley, Women to Watch, and we will be featuring Kate Stewart, the VP and GM of Stryker ENT here in Minnesota. So please please go under the events tab and register for those upcoming events. Once again, thank you so much to our experts and moderator. Thank you to all of you for tuning in. The replay will be emailed out to you in the coming days, and please share with anyone who may be interested. Otherwise, I wish you all a wonderful day. Take care of yourselves and others. Thank you.